Thank you very much, Julian. It's a pleasure to be here and an honor, and it was great to catch up with some old friends. Like I've known Chris Denny and Ari Srivatsan for a long time. I've gotten to know Sharon DeVoscar through the K-12 grant and met Vivian through our mutual interest in cancer predisposition and read about Noah, the review Noah and Chris wrote on nanoparticles, which I'll talk about a bit. I've never been so wired with these microphones. I take that back. There was a time in college when I was wired, but I digress. So I'm going to talk about targeted therapy for neuroblastoma, but I want to mention a couple other areas which I consider equally important or critical. One is what we call molecular profiling or personalized medicine, where one analyzes the genome of the cancer cells to identify the oncogenic drivers and potential targets for therapy. So that really makes targeted therapy possible. And the other area is analyzing the germline of patients to identify their susceptibilities in terms of cancer predisposition, but also susceptibility to side effects of various drugs. So these are other very important areas. I'm talking about applying targeted therapy to neuroblastoma, but the approaches and even some of the agents I'll discuss could be used for virtually any solid tumor or any solid tumor that expresses the target. So even though it's on neuroblastoma, it really has more broad implications. So I will not discuss any off-label use or investigational use from drug companies. I have had support from Ignyta to study drug resistance. I've also had support from the NIH and these various foundations that allowed us to do this work. So I'm talking about neuroblastoma, and some of you know very well what that is. But simply put, it's a very interesting, and I call enigmatic tumor. It's a tumor of the peripheral nervous system, not a brain tumor. Tumor of postganglionic sympathetic neurons. It's the most common extracranial solid tumor in children. Accounts for 8 to 10% of all cancers and disproportionately to deaths from cancer. What made this disease interesting to me back before most of you were born, I guess, is that this tumor had a propensity to undergo spontaneous regression. And although I'm not going to talk about that in great detail, the pathway, one of the pathways I will talk about, we think is integrally involved in that phenomenon. Also, there were some patients who had a mature form of neuroblastoma called the ganglioneuroma. So there's neuroblastoma, ganglioneuroblastoma, ganglioneuroma. So that's going along the differentiation spectrum. So some particularly older patients, even adults, would be found incidentally on chest X-ray or some other imaging that they had a mass that turns out to be a benign ganglioneuroma. And we think that started as a neuroblastoma, and instead of regressing, it matured. Unfortunately, the majority of the patients we see have high-risk disease. And from an age perspective, over 1 year of age, or 18 months now officially, is the age above which you tend to do less well. And it's because the genotype of the tumor is different in those patients than it is in the younger patients. And the majority of the patients over a year of age have either large tumors you can't remove, large unresectable tumors, or metastatic disease. Over half of them have metastatic disease. So here you see an infant with an adrenal primary and metastatic disease causing this hepatomegaly, and there's skin metastases. But that child not only will do well with therapy in almost all cases, but in many cases doesn't even need therapy. I mean, literally, you can say he's probably going to get better on his own. We don't need to treat him. And I'll talk a little bit more about that. Conversely, here's an older child, again, small adrenal primary, metastatic disease, but the pattern is different. This child has tumor that has invaded the bones of the skull and orbits, the periorbital bones. He has periorbital ecchymosis and proptosis. You can see an enlarged lymph node there, or not, but there is an enlarged lymph node there. And this child has a very poor prognosis. So how poor is his prognosis? Well, this is a series of studies through the Children's Oncology Group starting back in 1990 up to about 2012. And you can see that early on the prognosis was just about 25% of these patients. And that includes patients who were younger, who have a better outcome. And then you have these groups where it's shifted up, but not tremendously, as a result of bone marrow transplant primarily and more intensive therapy. So there's sort of a plateau here around 42 or 43%, and we've had a hard time getting above that. So if you think of the overall cure rate of childhood cancer is 82%. There's certainly diseases like ALL and Wilms and Hodgkin's and germ cell tumors where we can cure upwards of 90+%. So this has really been a difficult tumor to get on top of. So the rationale for developing targeted therapy is as follows. The improvements in high-risk neuroblastoma cure rate have plateaued, as I showed you. Despite maximally intensive multimodality therapy, high-intensity chemotherapy, radiation therapy, surgery, immunotherapy, double stem cell transplant, et cetera. And so we're still not curing all these patients. The survivors experience significant short and long-term toxicities, so we need more effective and less toxic therapy. If you look at the survivorship patients who survive this intensive therapy, a lot of them have significant long-term chronic problems with hearing, with their heart, with their growth, with a lot of things. Therapy should be targeted to the specific genes and proteins and pathways that are the oncogenic drivers of those tumors, if we can identify those. And if we are able to do that, targeted therapy should be more selective and effective and less toxic than the conventional agents we've been using. Targeted therapy approaches include targeted drugs that target a pathway, targeted drug delivery using nanoparticles, which I'll talk about, immunotherapy, which targets specific antigens, and even targeted delivery of radiation therapy using like MIBG, which is radioactive and goes to wherever the tumor is in the patient, based on its selective uptake by the norepinephrine transporter. So I'm going to talk today about 2/3 of the talk is on targeted drugs, and 1/3 will be on targeted drug delivery using nanotechnology. So I'm going to talk about targeting receptor tyrosine kinases. And the reason for targeting them is as follows. So receptor tyrosine kinases play important roles in regulating cell survival, growth, and differentiation. They're frequently activated in cancers by translocation, mutation, amplification, or overexpression. And another nice thing is receptor tyrosine kinases are expressed on the surface, so they're more accessible. If you have an oncogenic driver that's in the nucleus, it's a much harder thing to target. Inhibition of these RTKs that are activated in specific cancers should be an effective approach to therapy. And therapy can be individualized to the targets that are important for specific patients or their tumors. So rather than treat everyone with a EGFR inhibitor or an ALK inhibitor or whatever, we target only patients whose tumors have activation of that pathway. So I'll put RTKs in perspective. In the human genome, there are 90 receptor tyrosine kinases. And I know because I counted them. So 32 of them are cytoplasmic kinases, those are the ones in blue, and 58 of them are receptor tyrosine kinases, shown in red and gray. And these fall into 20 discrete families that share homology. So we will be talking about one family in particular, the TRK family. It's not the von Track family, it's the TRK family. And I'll talk a little bit about ALK, which is also mutated or activated in neuroblastomas. But that's largely other people's work at our institution, so I won't talk about that too much. So if we look at the role of receptor tyrosine kinases in neuroblastoma, there's TrkA, TrkB, TrkC, and ALK are the main ones. Not that others cannot be involved. So TrkA, B, and C are very homologous. They're homodimers. They only form homodimers. They bind homodimers of ligand, NGF for TrkA. BDNF for TrkB, and NT3 for TrkC. TrkA is expressed predominantly on favorable neuroblastomas, especially in infants. And we think this pathway may account for the spontaneous regression or differentiation that occurs. So the absence of ligand, if you have TrkA expressing cells, you put them in culture with NGF, they not only survive, but they differentiate, and they become terminally differentiated. They stop growing. If you put them in the same medium without NGF, within a week, they're all dead. And that's sort of the equivalent of spontaneous regression. And so in the presence of NGF, they can differentiate. And we think that comes from normal reactive invading Schwann cells, but that's another story. So interestingly, this very homologous receptor, TrkB, is expressed in the unfavorable tumors, especially those with MYC amplification, which we know is a very high-risk population. In contrast to these cells make their own ligand. And this activation of this TrkB BDNF pathway is associated with very aggressive behavior, invasion, metastasis, drug resistance, and angiogenesis. So TrkC seems to be expressed in a subset of the TrkA patients, so I'm not really going to talk about them. And finally, ALK undergoes somatic activation in 8 to 10% of high-risk neuroblastomas. They have activation of the kinase domain. And also, in germline mutations in ALK, actually activating mutations in ALK, are responsible for most cases of hereditary neuroblastoma, probably 75%. So one slide on ALK. ALK is activated by kinase mutations, as I mentioned, sometimes in tumors by amplification or other mechanisms in, again, 8 to 10% of the tumors. It's associated with high-risk neuroblastomas. Crizotinib is a selective ALK inhibitor. It also inhibits ROS1. It's effective against some but not all activating mutations. So some are inherently resistant if they occur in the tumor. Nevertheless, resistance develops fairly rapidly in almost all cases. And so second-generation ALK inhibitors are being developed, and these are the names. And actually, this is one we're going to talk about in just a few minutes, Entrectinib. So now we're getting back on track. Sorry. So this is TrkA signaling, and the signaling of TrkB and C are pretty much the same. It's a canonical tyrosine kinase. It signals through, when ligand binds, there's autophosphorylation. You create docking sites of signaling proteins, and they signal primarily through the RAS-MAP kinase pathway and the PI3 kinase AKT pathway, and others as well. But there's very little difference that we can find between TrkA signaling and B or C. They're actually quite similar. So, as I said, NGF in TrkA-expressing tumors comes from the microenvironment. It's not made by the cells. And in the presence of ligand, phosphorylation occurs, activation, differentiation occurs, and you can ultimately get mature ganglion cells from this. The same TrkA-expressing cells in the absence of ligand, as I mentioned, leads to programmed cell death or apoptosis. There's an interesting isoform I won't really talk about beyond this slide, but there's a truncating mutation of the extracellular domain. It results in loss of the ligand binding site, but constitutive dimerization. And this leads to constitutively active signaling, which resembles the TrkB pathway. And these cells just proliferate. They don't differentiate. So this is the TrkB story. It's a little different. And we're just pretty much going to focus on this one pathway. There's some truncating mutations that probably just result in decoy receptors. But these cells make their own BDNF. It binds to that same cell or its neighbor, leads to autophosphorylation, and causes these other changes to occur that result in more aggressive behavior, including the proliferation. So to summarize this, the TrkA cells, TrkA-expressing cells are the clinically favorable group, generally infants, generally low-stage disease. They do not make their own ligand. In the presence of ligand, they survive and differentiate, and it actually results in inhibition of these other behaviors. So in contrast to TrkB, they're associated with the unfavorable tumors, as you'll see, the high-risk neuroblastomas. They make their own ligand. they do survive under adverse conditions, low oxygen, low glucose, et cetera, but they don't differentiate, and it promotes invasion, metastasis, angiogenesis, drug resistance. So anyway, so that's our main focus in terms of this therapy. So this is a study from Shahab Asgharzadeh at CHLA, work he did with Bob Seeger a while ago, showing if you look at the pattern of expression of essentially all genes in the tumor genome, and the median level of expression is presented as 0. So you can say the majority of these high-risk tumors express very low TrkA. Some express higher TrkA. Some of these are the truncated form. If you look at TrkB, almost everything is above the line. So this clearly is a commonly activated or overexpressed gene in the human genome. We know from our in vitro experiments, if you put in TrkB into a TrkB null cell, the cells make BDNF. So it upregulates the ligand, leading to this autocrine pathway, exactly, just like this. So just the overexpression of TrkB can lead to this, and we know that amplification almost always leads to overexpression of TrkB. So we decided to target this pathway. So early on, we worked with a company called Cephalon and a drug initially called CEP701. It was later named Lestaurtinib. And these are all indole carbazole derivatives, as you can tell. That's a joke. And so this is a prodrug. It gets converted to this drug 751, and this is 701. This is the activation, but both of these are active. So if you look at here, this is TrkB expressing cells exposed to well, not exposed to 751, but exposed to ligand, compared to no ligand. So you can see you go from this to this in like 5 minutes. There's tremendous phosphorylation response to ligand. But if you add this inhibitor before you put in the BDNF, then you can progressively inhibit the autophosphorylation in response to ligand in a dose-dependent manner. So you can see here it takes 100 to 200 nanomolar, and that'll be important later when I show you Entrectinib, which is more potent. But we could eventually shut it off completely, but even inhibition in this range is probably enough to cause cells to die. So,
so this is phosphorylation, right? You're looking at?
Correct, thank you. This is a immunoprecipitation of TrkB and then an anti-phospho-TrkB antibody Western.
And so the TrkB is constitutively expressed there? It's always there?
Yes. So it's expressed at very high levels, and just within 5 minutes you get this level of autophosphorylation response to ligand. So the amount of receptors, I should have put the TrkB Western as well, but it was very uniform across this time frame. So this is a selective inhibitor of TRK and FLT3, and this was used for FLT3 positive leukemias. But at 10-fold higher levels, it inhibits the VEGF receptors. At 100-fold level, PDGF and FGF, and at greater than 1,000-fold, a lot of other kinases. So it wasn't very selective. It was considered dirty or promiscuous or whatever sort of terms, shades of gray and so forth that you want to say. But so that's why it wasn't as popular. And but anyway, we did some in vivo experiments. Showing that if we put this in, it's actually in a pump here, and this is the tumor on this side, and this is a treated tumor on this side. You can see that without treatment or with control vehicle, the cells grew very quickly, whereas with continued treatment, they sort of plateaued here. And they would eventually recur once you stop the drug, but at least controlled the growth of tumor over this period of time. And we were able to show that it was inducing apoptosis. So this is a DAPI stain that just stains DNA, and this is a tunnel stain which stains fragmented DNA of cells undergoing apoptosis. This is the control tumor. This is the treated tumor. So you can see here where the nuclei are, and you can see here they're all sort of pale, smooth staining, and here they're more clumped and irregular, which already tells you there's something wrong in these. And you can see by tunnel staining, many, not all, but many of these cells are undergoing DNA fragmentation or apoptosis. So we tried this in combination with a chemotherapy agent. We used cyclophosphamide or CPM. And in the tumors that we treated with cyclophosphamide alone, you could see they responded here, and then they didn't really respond to the second dose, and then they just grew right through the third dose. So by this time, they're completely resistant. Whereas if we combined the CEP treatment with cyclo, they responded more profoundly, and they remained under control until we stopped giving the drug. But we showed we could get some additive activity. So we moved to a clinical trial, and here's the drug where it was 5 days on, 2 days off. It was a pill giving twice a day. And Jane Minturn in my lab did this work. And this was a phase 1 trial through the NANT, or Neuroblastoma, New Approaches to Neuroblastoma Consortium. And we tested various drug levels, and these are the corresponding levels here. This had been tried in adults, and this was the adult phase 2 dose. So we did a bioassay, and this is comparing phospho-TrkB with TrkB. We took plasma from patients an hour after they'd received the drug and mixed it with medium and put it on cells expressing TrkB, and then added BDNF to see if we could still activate the receptor. And if we did pre-serum and post-serum, you can see there was no real effect here at this dose. At 55, dose level 4, we saw some modest inhibition of phosphorylation here. And then when we got to higher levels, like 70 or above, we got rather dramatic inhibition. And we know from our in vitro studies, this is enough to cause the cells to die. So we were encouraged by this, and it was actually overall very well tolerated. So we did this clinical trial. It was well tolerated. Doses much higher than the adults achieved. We had modest hepatic toxicity, so transaminases went up like 2 to 4-fold. And if you treat ALL, you allow them to go up 10-fold before you reduce the dose of 6-MP or methotrexate. So it was really pretty modest hepatic toxicity. We've determined that dose level 70 milligrams per meter squared twice a day was what we needed to achieve. Of these patients, 16 who had been treated at this level, 8 had a significant response. There were 2 partial responses, so 50 to 95% reduction in size. 2 mixed responses, some places responded, some didn't. There were 4 stable disease. But the median duration of response was 10 plus months, and some were 4 to 28 plus months. The overall response rate was 50%. So we didn't expect to cure patients with this, and we didn't. But we had patients who had failed intensive chemotherapy, radiation therapy, surgery, double stem cell transplant, immunotherapy, differentiation therapy, in phase 2 agents, phase 1 agents. And they were taking a pill twice a day for 10 months to a year or 2 years without any pain, without any side effects. Their tumor didn't completely go away, but it was controlled. So and that's about as good as you can expect with a biologically targeted agent, frankly. And we were pleased it was so durable. So the preclinical data supported pursuing this, but unfortunately the drug company was taken over and they killed the R&D of this drug, so we started investigating new agents. And we looked at some from various companies, and we are currently working primarily with Ignita, although we're still looking at the Loxo drug, which is a very selective TRK inhibitor as well. So this is the data for Entrectinib. And TRK is sort of trying to incorporate the TRK letters in there, TRK. So this is a potent selective bioavailable agent given by mouth. It's an ATP competitive inhibitor, and it targets the TRK genes, ABC, and everything we've tested targets all 3 of the TRK genes, but also ALK and ROS1. So ROS1 is mainly an issue for lung cancer. It doesn't really affect pediatric cancer much, but ALK is an important target for neuroblastoma, and it's actually effective in tumors that are resistant to crizotinib. So it's actually a very good ALK inhibitor. The IC50 is very low. You can see it's like less than 1 nanomolar in some cases, or in the 1 to 2 nanomolar range, so it's very low. In vitro, it inhibits target activation by ligand as well as downstream signaling. In vivo, it inhibits tumor growth, and it also crosses the blood-brain barrier. So one thing we've encountered in treating high-risk neuroblastoma patients is they also appear to have like a sanctuary, because sometimes the first site of relapse is in the brain. So this is helpful that it does cross the blood-brain barrier, although in a younger child you might worry about side effects. So here's the preclinical data, just showing how effective this drug is. Even at 1 nanomolar, there's a dramatic inhibition of phosphorylation compared to, this is no ligand and ligand like I showed you before, but you can get almost complete inhibition by certainly 5 to 10 nanomolar, and even 1's pretty good. We didn't see as complete inhibition of phospho-AKT or phospho-MAP kinase, but there are other pathways that are signaling through these mechanisms, and that could account for some of this. So we did in vivo studies in a mouse xenograft. So this is, again, time and the tumor growth here. And you can see the untreated tumors grew very quickly. The controlled tumors, bless you, grew more slowly. This is the event-free survival. And so controlled tumors died off within 18 days. And these tumors were still going at this point in time. So we did a combination study with irinotecan and temozolomide. So the red line is untreated. The orange line here is irinotecan temozolomide by itself. The blue line is entrectinib by itself. So it's actually better than irinotecan temozolomide. And then the green line, there was a modest but significant improvement when we combined irinotecan and temozolomide with entrectinib. So this suggests that doing combination studies could be of some value. So this agent went into clinical trials. There was 1 in Italy, 1 in the US. And these patients were selected because they had activation of a target. In most of the cases, the target was a translocation involving either TRK or ALK. But the response rate in those that had target activation was 72% in this study and 80% in this study. These were called STARTRK studies because they were focused on TRK, STARTRK-1 and STARTRK-2. And this was the disease control rate. So at the time of this was reported at ACR in 2016, 23 of the 25 patients were still on the drug and had disease control. So they didn't all have complete disappearance of tumor, but they were all still being controlled. So there have only been 2 that had relapsed. And the side effects were all pretty mild, and they all were 1 to 2 grade and resolved when reducing or stopping the dose. So we went on to a pediatric trial, which we're just getting going. This is called STARTRK-NextGen for the Trekkies out there. And the goal of this was to find the recommended phase 2 dose, to look at the pharmacokinetics in kids, to determine the progression-free survival, and to study mechanisms of resistance. So we initially started off with a 3x3 dose escalation study and we've experienced no toxicity, so there isn't any DLT, and we're probably far above the dose we need to have effective therapy. And then there will be expansion cohorts of patients who have target activation, starting with the recommended phase 2 dose in extracranial solid tumors, in intracranial solid tumors, and in neuroblastoma, because they do not have mutations or amplification usually, but do have overexpression, as I showed you. And then we'll do a basket expansion with this drug, among others, for patients who recur. So one thing that we're doing in the lab to support this study is to look at mechanisms of resistance. Because that's the problem with receptor tyrosine kinases, right? They work in many cases very well, and very few side effects, but eventually resistance develops. So we divided mechanisms of resistance into target-dependent and target-independent. So target dependent are things where either there's amplification or overexpression, so there's so much more of the target that the drug levels aren't enough to stop it all. Or there's some other mechanism of activation that renders the drug ineffective, translocation or mutation that inhibit binding. Target independent mechanisms are things that do not involve TRK but some other pathway, either upstream or downstream. So the upregulation of downstream signaling proteins like the MAP kinase or PI3 kinase AKT or is one mechanism, or downregulation of PTEN, which removes the phosphate group. You can have activation of other RTK networks, so in IGFR, EGFR, ALK, or RET, or other pathways. You could also have rapid drug efflux or metabolism by the cell, and there could be epigenetic mechanisms that are involved. And to overcome resistance, there are various approaches one can take. You can use higher doses of the drug if they can be tolerated. You could make second and third generation inhibitors to overcome resistance. You can use them in combination with conventional drugs or with other biologically targeted drugs that are downstream inhibitors or other RTKs. Or you could target the delivery to get a lot more drug in the tumor using nanoparticles, which I'll talk about in just a second. So to summarize the work on TRK inhibitors, TRKs are an attractive targeted agent for specific cancers with very limited toxicities. They don't work in all tumors that express the kinase, but the ones we've done have worked very well. And Noah was telling me about the LOXO inhibitor working very well in a patient here with an infantile fibrosarcoma. Resistance may develop due to mutation or overexpression and require alternative approaches or agents. They're best used in combination, we think. I don't think any of these agents are going to just cure patients by themselves. They need to be combined. But I think they can be very effective and add very little toxicity. And you can probably use less drug when you're combining it with such an agent. And they could be more effective if delivered in nanoparticles where you can get more drug to the tumor. So that's the TRK story, and now I'm going to talk about nanoparticles. So what are nanoparticles? And first of all, they're very small. That's why they're called nanoparticles. So why are nanoparticles interesting for drug delivery? The reason is that tumor blood vessels are very disorganized and leaky compared to normal blood vessels. And Dr. Maeda, back in 1985, coined the term the EPR effect, enhanced permeability and retention effect. So this shows normal blood vessels with very tight endothelial junctions. You get into the tumor and you have these holes or fenestrations in the endothelial lining, and then you get beyond it and it's tight again. So if normal blood vessels are very tight and tumor vessels are leaky, things of a certain size can pass through normal, pass through into tumors that will pass by normal cells. Sorry, I'm getting over a cold. So nanoparticles of the 50 to 200 nanometer size range, we think, are optimum to penetrate tumors by extravasation. They're then retained in the tumor, again, due to disordered vasculature and the lack of lymphatics. So normal tissues have a very efficient arterial venous lymphatic supply. So oxygen and glucose go in, CO2 and lactic acid come out, extra fluid gets removed, so everything works very, very efficiently. Tumors have a poor arterial system, a worse venous system, and usually no lymphatics. So things that get in stay in, which is an advantage. If you can get the nanoparticles in there, then they slowly break down. You get basically sustained release. So that's why they're wicked awesome. So here's the rationale for using these for targeted delivery. And this is, don't tell anybody this, because this is a little secret that we don't want anyone to know. But most conventional agents that we use, they're given at maximum tolerated dose, but only about 0.1% of the drug gets to the tumor. I mean, I told Chris Denny when I heard that, I cried because it's embarrassing. We give this horrible drug, and only 0.1% of it gets in the tumor. I mean, sometimes a little more, sometimes a little less. So and also they have a very narrow therapeutic window. So what's a therapeutic window? it takes this much drug to kill the tumor, but if you get to this much drug, you're going to kill the patient. So, or have a lot of toxicity. So you have this narrow window that you can deliver things in and not be too hard on the patient. If you could take that window and open it up to, what floor are we on? The third floor, the third floor or something, you have a huge range of where you can deliver drug and knock the socks off the tumor and have very little systemic effect. So nanoparticle encapsulation avoids a problem of solubility, which is a problem of many new anti-cancer drugs. They're initially made and they aren't very soluble. So they have to modify them and make new drugs and prodrugs, like irinotecan, which is a prodrug, to eventually get the tumor into the patient. There can be protein binding, which makes it difficult to get free drug into the cells. They can have off-target effects. And if we do this approach, we can get potentially 10 to 100 times as much drug in the tumors. I'll show you. You can have targeted delivery and take conventional and biological agents much more effective by delivering much more drug to the tumor. You also can reduce toxicity in two major ways. One is you give less total drug because you don't need as much to kill the tumor. And while it's circulating, it's in nanoparticles. So when you give free drugs are small and they just diffuse or they get rapidly metabolized and excreted. You're protecting the drug in these nanoparticles so it doesn't get degraded or secreted, but also it doesn't diffuse into other tissues. So you can have a tremendous advantage that way by protecting the systemic exposure. So this is to put these in perspective. So glucose is about 1 nanometer and antibodies about 10. Viruses are the range we're sort of shooting for, and it's around 100. And you can see bacteria, red cells, cancer cells, a dot, a ladybug, and a baseball. so this is definitely too big. So we're shooting for this size range, actually 50 to 100 more like, but this is the size range we're shooting for. So there are a lot of different variations of what are called nanoparticles or nanotechnology. So we're working with polymeric nanoparticles. Ours are called PLA-PEG. So PLA stands for polylactic acid, chains of lactic acid. What does lactic acid break down into the body to be? CO2 and water. So completely biodegradable, no accumulation of anything toxic. And we pegylate them, PEG, which also breaks down to make them more stealthy so they aren't confused with being viruses and removed by the macrophages. There are polymeric micelles, there are dendrimers, liposomes, viral capsids, and even carbon nanotubes. So actually there are some, they're called mesoporous carbon nanotubes. I love saying that. But this is the type we're using. This is the type that Chris and Noah have used in the past. And there are other things like gold nanoparticles where you just stick things on the outside, but gold's inert, so it doesn't do anything. Nanodiamonds. Most women like the diamonds, and quantum dots are used mainly for imaging. So a lot of different forms of nanomaterials. And then you can incorporate drug into these, or you can put things on the outside, stick into these, and then have them break down. So with nanoparticles, size matters. And I mean size in the Goldilocks sense of size of matters. So this just shows some examples of how uniform we can make these nanoparticles. And here's a flow diagram. You can see a very precise size around 52 nanometers with a very small coefficient of variation. So if things are too small, then they're widely distributed, they're diffusible, and they're not going to be very effective. In the 10 to 50 range, they're less stable, but more stable than these, but they have a low payload, so they can't carry much drug. In the 50 to 200 range, that's the Goldilocks size. That's optimal for carrying payload. And if they're too big, then even with PEG, they look like viruses, and they get engulfed. And even the smaller ones do get engulfed by macrophages of the liver primarily, but also the spleen. So this is the size we're looking for. So we decided we've done this with a number of different drugs and in somewhat similar effects. So the best effects have been with something called SN38. So SN38 is the active metabolite of irinotecan, but it's very toxic and not very soluble. Actually, SN38 was the drug the company made, but because it was so toxic, they had to make a prodrug. They had to attach a side chain, which made it inactive. Then it has to be metabolized by the liver, and then it could be active. So this is the active agent. Pegylated polylactide, those are the polymeric nanoparticles. That's what we're using. They're very biodegradable, and so it's very safe delivery. We actually made a co-drug or prodrug that covalently bound SN38 to tocopherol succinate, because this is very lipophilic, this is lipophilic. Combining the two, we increased the lipophilicity by 100-fold, and that allowed them to be retained in the nanoparticles much more effectively and for a much longer period of time. So we thought this would improve the delivery profile and could even overcome resistance because we can give so much. So this is an electron micrograph of a nanoparticle. It's actually not. I drew this. But so this is some people say a cartoon of a nanoparticle with polyethylene glycol on the outside. The co-drug here, the active agent is this red starburst here, and this is the tocopherol succinate. So in the tumor, they're covalently bound, but this is a very hydrophobic environment. When they get into the tumor, this is readily hydrolyzed in a non-enzymatic way into the two components. So if you think of this as the drug and this is the co-drug, they get put together like this and they have to break apart like that. If they get put together like this and they break apart like this, you're missing something here, you've got something extra here, and if they're both supposed to work, they may not work at all. So you have to know what you're doing. And I don't, but I work, and I mean that, but I work with people who do, and they know how to do this. And so I'm on their coattails. But so we decided, and we did a number of experiments, and they're very internally consistent, but I'll just show you one in vitro. So in vivo. So this is, again, time and size of tumor. This is the control tumors with no treatment. They just grow very quickly. Once they get to 3 cubic centimeters, we sacrifice the animals, and that's when they die, because they do die, actually. So we had regimens that were either 4 weeks or 8 weeks long. But here, this red line is treating the animals 5 days a week for 8 weeks with irinotecan and temozolomide. And I'm sorry, not all the legend came out here. So this is using nanoparticles, treating with the same dose per day, but treating twice a week for 4 weeks. So this is 5 times 8. This is 40 doses of irinotecan, sorry, just irinotecan, not temozolomide. And this is 8 doses of irinotecan. So we clearly had an improvement in the growth curve. This is treating them once a week for 8 weeks. So it's a longer treatment, but the same number of doses as this, and that looked even better. Then we treated twice a week for 8 weeks. So that's 16 doses, 40% of this. And we had disease control for a long period of time. But if you look at the survival curve, this is the control. This is irinotecan itself. This is the twice a week for 4 weeks, once a week for 8 weeks. And look where we are with twice a week for 8 weeks, 40% of the total dose. This is 180 days. That's like 6 months. In the life of a mouse, that's a very long time. So we had, in most of the animals, they had no tumor whatsoever. We lost 1 tumor, and I think there were 1 or 2 others that had small tumors. But we had tremendous disease control. Normally, when people show a shift of something like from here to here, they think, oh, wow, this is amazing. We've really hit the jackpot here. But here, we're curing almost all the mice with a fraction of the dose of a single agent. The nice thing about SN38 in nanoparticles is we can use this to treat any solid tumor in children or adults, any that have the susceptibility of the leaky blood vessels. So very slow-growing tumors are probably not going to be as affected by this if they don't have the leaky blood vessels, but rapidly growing tumors, maybe even rapidly growing tumors in the brain could take this up because of their disordered vasculature. So we looked at the level of drug in the blood and in the tumor in these patients. So this is the blood, this is the tumor. This is irinotecan given by mouth, and this is the nanoparticles. And these are at different hours. So we're just going to focus on these two. So the irinotecan itself doesn't really do anything. It's only the SN38 that counts. So if we give the same dose on day 1 in the blood, we have 8 nanograms per ml of SN38 at 4 hours, and none after that we can measure. We have, and there's 10 in the tumor. If you look at the nanoparticle delivery, instead of 8, we have 4,000. That's 500 times as much drug. That's because it's circulating in nanoparticles. And then it drops off after that. But still, I mean, even at 72 hours, it's much higher than it is at 4 hours with free drug. If you look at the tumor, there's 10 nanometers, and actually 10 is the limit of resolution. We can barely measure at 4 hours how much SN38 there is. And here we have almost 2,000. So again, almost 200 times as much drug. And we had 75% of this dose at 24 hours. We had 50% at 48 hours and 25% at 72 hours. So we got sustained delivery. So this shows you how you can give it only once or twice a week. We think twice a week is probably optimum to get a tremendous sustained release and disease control. So anyway, we think that nanoparticles allow this EPR-targeted delivery of drugs to avoid problems of solubility and protein binding. We can increase drug delivery by 10 to 100-fold while simultaneously decreasing systemic exposure. The type, size, and composition can be tuned or optimized for dwell time, drug payload, and drug release kinetics. Nanoparticles can incorporate imaging agents. They can be surface modified for stealth and for affinity targeting. And we can also make prodrugs to increase the retention in the nanoparticles and deliver 2 agents or even more, I guess, simultaneously. That could be synergistic. So we think there's tremendous potential. I can tell you in all honesty, I guess I have to do that. I can tell you in all honesty that taking the results we get in animals and doing it in a patient are very different. We can't get quite this good a response, and there are ways around that we're working on. Also, there's no way to target a nanoparticle to the tumor. It's not like you put like an antibody on the outside and it goes right to the tumor. It has to get into the tumor by the EPR effect. Once it's into the tumor, it may stick to the tumor, be taken up into it like a Trojan horse, and then release the drug if it has an affinity ligand. But it doesn't, we don't know yet how to target it to the tumor. But if we can get 10 to 100-fold, we can go from 0.1% to 1% or even 5% or 10%. The therapeutic window is wide open. So we're very excited about the potential of this to take even conventional drugs that we're giving that have significant side effects and dramatically reduce the toxicity, deliver less drug, but have much more efficacy, as we've shown in this model. So I wanted to acknowledge all the people who have done this work in my lab, so Venkat, Kamudi, Farrow, and Harsha, as well as the TRK team is Suzanne and Pangwan and Sam Linares. And these are the nanoparticles. These are the smart guys over here. Michael Chorney and Ivan Alferiev, and these are the people who helped develop the clinical trial for Entrectinib. So I'd like to thank you for your attention.